Exam one review. I'm going to share my screen here so that you all can see the schedule for the next reviews. It's in your assignment announcement section under exam review schedule. This is exam one. Review with myself, Dr. Morton Ford, is tonight, October 16th, 6 p.m. Eastern Standard Time. And then exam two, here's the schedule, so you all can plan accordingly for that. And then exam three. At a minimum, please commit to at least reviewing the recordings that will be provided for you. Remember to also, you do need to download the exam. The exams are usually available 1 hour prior to start of exam time. In the event that you think you need that exam proctored, make sure that you send an email to Dean Brown and also your campus dean, including myself, requesting that that exam be proctored. You will need that 72-hour notice prior to having, so that can be scheduled accordingly. A place and a person will need to be available. So make sure you remember that. If you have any accommodations, make sure you've sent that to your professors. That's something we ask that you all do every term. Make sure that you have your 2 devices and your 2 chargers. You will need your ID. You will need a dry erase board and or a clear protector sheet. Paper is not allowed. All right, so we will go ahead and get started here reviewing. So our first slide here, I'm going to share my screen, like who does what. So what we're referring to is the registered nurse and the LPN. Try to get my screen straight here. Okay. So the RNs are educated to develop nursing care plans independently using all the steps of the nursing process, including that nursing diagnosis. So both the RNs and the LPNs, they can administer medications under the direction of the healthcare provider. That's where we get our orders from. So doctors that have prescriptive authority, orders to give orders. So that's what we get at. We get those we administer our medications or perform our treatments on our wounds based on what those orders actually say. Remember, RNs are taught in-depth assessment skills, including comprehensive physical assessment of all body systems as part of their basic education. So the RN have the authority to delegate tasks to LPNs and unlicensed personnel. Both the RN and the LPN can collect data, but the LPN's focuses on that basic data collection, such as vital signs and therapeutic responses. So the RN's response is more comprehensive. So again, for the PN, of course, we can administer medications and we can collect that basic data from our clients as we interact with them and collect that subjective data from them.
Dr. Morton Ford.
Mm-hmm.
I can't see your screen.
I'm not sharing anything right now.
You're sharing? Okay.
Yeah, I'll share it in just a moment. Just giving an overview, and then I'm going to share the PowerPoint.
All right. Thank you.
So just remember that, like we just said, the LPN collects and reports that data, but they do not make that initial that nursing diagnosis. LPNs do not make those initial assessments either. So if that client is just coming in, that initial head-to-toe assessment is done by that registered nurse, not that LPN. We can reinforce teaching. That initial teaching is also done by the registered nurse as well. Okay. So just remember the different phases of the assessment process. Assessment, the nursing process, the piece of assessment. We're collecting all that data. We share that data with the registered nurse. The planning part, they provide input and identify like the basic care needs and start deciding what needs to be done, what interventions needs to be implemented. And then the interpretation or the implementation phase is what we actually do. We carry out those interventions and then we make note of the client responses. For example, if an intervention was to administer pain medication, of course, we would reassess that pain. The pain has not lessened. If the client is still exhibiting nonverbal cues that there is pain there, then that would mean that pain medication was not effective. So we carry out those interventions, paying attention to what the client's responses are, because we would need to also report that. Because during that evaluation phase, we're looking to see if those goals were met, did that patient progress, or do we need to, or should there be another intervention in place? Okay, so here we go. I'm trying to share my screen now. Okay. All right. So let's see from current slide. Okay, so let me move us over here. The assessment phase, the OPN and the RN, we both gather that data independently during this phase right here. So if you notice, here, assessment and the implementation is where the LPN works more independently, even though they're not an independent practitioner, but they work independently doing the collecting the data part and then the doing, the actually doing the different interventions. So the RN does come up with a nursing diagnosis based on NANDA. And then during the planning stage, both the LPN and the RN, they actually collaborate. And then evaluation, we report what we've recognized, that the patient complained of less pain, whether not as many facial grimacing, was the temperature back to normal, and we evaluate and see that the intervention that we implemented, did it do any good? Okay. So, like I just mentioned, the LPN functions in an independent role in the nursing process by collecting data, getting that subjective data. The RN creates a nursing diagnosis. This is the same slide, just looking at it in a different way. The LPN collaborates with the RN on the plan of care and the evaluation of the client outcomes. Safety is priority. We always want to be thinking about safety. So is it enough lighting? Is this person at risk for falling? We want to make sure pathways are clear, that there's no clutter in the room. Even in that, we have to go to the patient's home, identify, even though it's their home, sometimes things puts us at risk for not being safe or tripping and falling. If it's not a well lit area, do the person need night lights? Does a person have a rug that may slip, especially if it does not have that non-slipping padding up under it? But we always want to think about safety. Before collaborating on the plan of care with the RN, the LPN must assess the client's understanding first. What do they know of their condition and what are their priorities for change? We want to understand and have a conversation about, well, do this person even know that they have hypertension, high blood pressure? What is their understanding of what that is? Because our interventions might be educating, or for us, we would provide that, we would reinforce, we would not do that initial educating. And then if whatever the intervention was that we've come up with, if the patient does not think or is going to be non-compliant with it, then we want to think of alternatives. So we want to know, what does this client know about the condition? They may or may not know. And then is it a priority to them to improve, to be able to manage their care? The client might be where they might say, well, hey, I just want to go into a skilled nursing facility and just let the staff there take care of me. Some patients, hey, this is important. I want to go back home. I want to be as independent as possible. Okay. So do you know the LPN will most often reinforce? So look for those keywords, reinforce, initial. We do not do the initial teaching. The RN does those. So the LPN will most often reinforce the client teaching. And then we also notice changes to the plan of care during the implementation phase of the nursing process. This is us doing, administering that medication for fever. This is us checking that blood pressure. The nursing interventions, they are patient specific. If we have 5 patients on our team that have diabetes, or 5 patients on our team that has hypertension, it doesn't matter. We will tailor the care plan, the intervention specific to that person. The person, and we'll just say patient in room 201 has hypertension. They may be in because they actually have a broken hip. So they're having hip surgery. So we would need to add in that. Some of their interventions might be similar, but we want to provide that individualized, specific care for each of our clients. Okay. Okay. When collaborating with the registered nurse, plans of care outcomes should be measurable. They should be realistic and time specific. So we need to be as specific as possible. How are we going to determine if we're doing any good? What is going to be the thing, the tool, the measurement that's used to determine whether or not the intervention that we are implementing, the doing part, is it doing any good or not? Administer Tylenol every 4 hours for a temperature that is, that they sometimes they give a range. And so how do we know if that Tylenol is working? Go back and we recheck it. It is realistic that we can administer that Tylenol. Some interventions you want to, when we say realistic, be specific with the settings that you're in. So if someone's at home, we want to do interventions that they can do in that type setting rather versus acute care setting, because supplies and things that are available in acute care setting, a person might not have them in their home. So we want to make sure what we're coming up with is actually realistic and then time specific, because we do want to evaluate to see if the interventions that we're implementing are actually doing this patient some good. Okay. So subjective, objective. Subjective information is what we get from the subject. Depends if sometimes we call them patients, we call them residents, but nevertheless, that's the information we get from that person, the subject. They are stating these things. I feel sad today. I have hypertension. I check my blood sugar, every 2 hours. The subject, the person, the patient is communicating that to you. So for objective, this is information that we as the nurse are gathering using 4 by 5 senses. So what are we seeing? What does that skin feel like when we're listening to that blood pressure or that heart sounds? Is it regular when we're feeling for the pulses? Is it regular or irregular? When we are changing the dressing, we're measuring the dimensions of it. We're not going to put the dressing close to us, but we want to make note of whether or not that wound has an odor or not. So for objective information, these are some examples. The vital signs that we obtain: skin turgor and color, give that description. Readily reforms, skin is warm, dry, flaky, whatever those descriptive terms that we use. What is the appearance of that wound? What does it look like? Patient level of consciousness: alert, oriented times 2, 1, 2 can be person, place, or whatever it is, but that's objective information. Okay. We're always critically thinking. We're always collecting information. Remember, at a minimum, we're going back to evaluate and check on our patients every 2 hours at a minimum. But most of the time, we go back and interact with our patients more than that. And each time we need to be collecting data, be thinking, okay, we've established our baseline. Is this a change from the last time that I interacted with that person? So we do want to verify data and arrange it in an organized way. That helps us to decide whether or not there are any gaps. Are there any missing pieces of information that we have not collected? And so we do want to analyze that data and test it out in a purposeful, outcome goal oriented way to see if what we're doing is actually making a difference, if it's doing any good or not. Okay, so here's some examples of critical thinking. Notice a change in a patient's condition: drop in blood pressure, altered mental status. First, when you went in, the patient was responding readily. They were responding appropriately. They knew their name, they knew where they were. Then you go in, patients, they're answering questions, but the answers do not match the questions that you're asking. That's a change in mental status. You went in at 8 p.m. and you checked the blood pressure. Blood pressure was due to be checked again at midnight. That reading was drastically lower. We've learned what the normal range is, and this blood pressure is lower. And so what do we do? What do we do? We should be thinking about, well, hey, did this patient take some medication? Is this a new finding for this patient? What's the next steps? Do we change the position? Do we offer fluids? We call the doctor. What are those next steps? So it's just a fluid process. We're always collecting information, comparing it. We want to be noticing if and making note of if there are any changes in our client's condition. We always want to prioritize patient care. How much care does this client need? How much assistance do they need? Is this person a total care patient, or is this patient stable, unstable? Because we'll talk about delegation a little bit more. If a person is unstable, we're not delegating any of those tasks to an unlicensed personnel that they would normally do if that person was stable. So we always want to be collecting information and determining if there's a difference. Is this an expected outcome? A person that just come back from surgery, they we kind of expect that they may be in a little pain. So it's kind of expected that they may be in some pain. But then if they're in excruciating pain, well, maybe that's a little different pain. That's kind of not expected. And so what is it that we need to do? Probably more than likely we'll need to do our pain assessment and then report those findings. Look at that wound and gather all that information. So we're always collecting data and trying to interpret it and see if there's any connections with any of it. So here are the different cognitive levels. Some information, we just recall it. We just remember what it is. And then comprehension, we actually really do understand what that concept is all about. Application is using what you know. So an example could be we are in the skills lab and we're learning our landmarks to administer an injection. Okay. And then we've learned it, we've checked off. So that means we're ready to go to the actual setting and actually clinicals and take care of our patients. One of our patients that day, they need an injection. So application, we're taking the knowledge and understanding, that comprehension that we have, and we draw up that medication, identify our landmarks, we actually administer that medication appropriately after going through our medication rights, checking the doctor orders, and all of that is knowledge all the way through application. But then this analysis part is breaking down complex information into basic parts. So we administer that medication for, we can just say pain or fever, or we administer that medication for an infection. So we know that we come back and check the patient's temperature again. We gave the medication because they had a fever. When we check that patient's temperature again in 4 hours, okay, did this temperature improve? Did it get worse? When is this medication due again? Is it due? If it's not due and we see the temperature getting worse, what do we do? So we need to report these findings to the healthcare provider. So it's taking all that information that you've learned over all these terms, med-surg, OB, and putting it all together. All that information that you recall and now that you have an understanding of, and for the most part, you've been applying it in your clinical settings. So when you get your team of clients, your team of patients, when you go out and do your mentorship, you're having to think it through from knowledge all the way down to analysis. Because remember, you're going to be the person that they're coming to in the event. Lab is calling you. Potassium is, a patient in room 201, potassium is 3.7. Because you recall potassium normal range is 3.5 to 5.0. Okay. All right, we'll make note of that. That's normal. But if lab calls you and says that potassium is 7.7, you recall, hey, potassium should be between 3.5 and 5.0. What's next? That means they're hyperkalemic. What do we need to do? And then how do we take care of that patient? What orders would we expect to receive to provide appropriate care for that patient? Are there any precautions? Are there any vital signs we need to take? So we need to think about safety. Okay. The Tanner model is used in how we make judgments. The information that we have gained, that foundation, like I said, over the couple of last terms, you've been gathering information, OB, Peds, med-surg, and now in leadership, we've been gathering all of that information. Now we can break it down, interpret it. What does it mean when we are faced with a client that has more than one disease process. That also requires us to perform procedures, administer medication, to put in a Foley catheter, remove a Foley catheter. So the tunnel model helps us to think it through. We have to be able to interact with our patients, see what their preferences are, and also see what information they know about the disease process and how to actually manage it. So ethics is a system of standards of moral principles that direct actions as being right or wrong. Ethics is concerned with the ways people, either individually or as a group, to decide what actions are right or wrong. If one has the right to do something, or if one has a duty to do something. So when we get assigned our patients, when we go on to work, we have to read those care plans. So those individualized specific care plans tells us what to do in order to take care of that patient. Those care plans come from the orders. It comes from that collection, that data. And we have a duty to take care of those patients. No, we don't want to use bias. We don't want to belittle. We want to provide the best care we can with our patient. Our patients have the right to refuse, medication and treatments or whatever, but we support them in that. We support them in their autonomy. Okay. So that right or wrong, personal and professional ethics. Professional, the State Nurses Practice Act says that it is lawful for us to perform a procedure or a task. But personally, the nurse might not want to take part in that task or that procedure. So there's sometimes where, they bump head. It is lawfully okay for you to, we'll just say, paint someone's fingernails. We're going to just use something that's not so specific. But it's okay. The law, the Nurse State Practice Act says, hey, the nurse can do that. It's lawful. They can do that, as long as they're using appropriate infection control measures. They're doing the patient's nails as they require, the length. They're taking heed and making note if they have any contraindications to clipping the nails and all of that. But personally, you might not like fingernails and like to do that task if that's one of your tasks at your job. So sometimes personal ethics and professional ethics may bump heads or come in conflict with each other. But the thing is, professionally, it is lawful based on my scope of practice in whatever state that you're in. The State Nurses Practice Act says this nurse can perform this task. But professionally, I might not want to. Okay. Ethical responsibilities as a nurse. We are that client advocate. We want to be accountable. We may even have to do colleague reporting. If you see, your coworker, doing mishandling the patient, their medications, we want to notify our immediate supervisors. And of course, we will have to, make a statement and write all that out. But we need to, that's being an ethical, responsible nurse. So just make sure that you report that. Some ethical principles: justice being fair to all. The client sometimes depends on what settings that you're working in. I know the emergency rooms, a lot of times, if a person is underinsured or uninsured, or for whatever reason, they just like to come to the emergency room to, get that type of care on that day of the week or that day of the month. No matter if that client is non-compliant with their diabetes medication, they're non-compliant with their hypertensive medications, it doesn't matter. We still have to provide the best care for all of our patients. That is being just, and that's being fair to all. Non-malfeasance, doing no harm. We want to keep our call lights in reach, our beds in the lowest horizontal positions. Beneficence, we want to do good. We may have to make that phone call to that healthcare provider. Hey, we realize we're giving this order says, whatever it says to administer this medication, but I've noticed when I give this medicine to this client, they're having this reaction. Or, lab reports the lab value to us. We want to make sure, especially if it's critical, outside of the range or outside of the normal value, we want to make sure that we're reporting that. Autonomy, the client has the right to refuse. They have a right for their privacy. We have to support that. And then fidelity, just being true. And remember, this does include HIPAA as well. We want to keep those things private. If we're working in the emergency room and our clients get transferred to med-surg, then we no longer have any part in that patient's care. So we should not be looking through the medical records. If we don't have any direct care to provide to that client, then we should not be involved in their medical records. We want to keep private things private. So make sure that we are disposing of private information in those receptacles. They're usually everywhere. They have them, they're locked receptacles, making sure that we're blotting out identifiable information on paper and disposing those in the appropriate receptacles. So beneficent paternalism, it actually goes against autonomy. So we have a client, parent, or guardian, they've made a decision about their child or the patient's treatment. With beneficent paternalism, the healthcare provider comes in and say, nope, I disagree with the decision you made. I know what's best for your patient or your client or your child. And so with this is only used in extreme circumstances and emergency situations. The courts are petitioned. A court order is obtained and the information is presented to the courts. So yes, beneficent paternalism actually goes against the decision that the parent or guardian has made for that patient or that child. It's like the opposite of autonomy. Okay. Legal aspects of nursing care. Remember, our State Nurses Practice Act is like at the top. The different facilities, their policies and procedures should match what that state's Nurse Practice Act say, but it will vary based on the setting, urgent care, acute care, skilled nursing facility. But nevertheless, our facilities should not be asking us to do anything in their policies and procedures that the state Nurse Practice Act say that we can't do. They should match. And so in the event that, their legal proceedings, that's what they'll go look at. They'll look at the State Nurse Practice Act for where you're licensed, that facilities, policies, and procedures to say, they match. Because sometimes people can have bad outcomes and no one did anything wrong. But this will be where they get the expert nurse to look at the standards of care and see, what was actually done. How do they know? That's why it's so important to document. You want to take the time to make sure you're documenting because in the event that there's some type of legal action, they're going to come back and look at the Nurse State Practice Act, that facilities, policy, procedures, the standards of care, and then what was actually documented. Okay, so it's important for you to know this is just saying the same thing. Know what your State Nurse Practice Act says that you can do. What's in your scope of practice? It's important for you to know that. Okay. Content of the Nurse Practice Act, the general procedures, the licensure process, the responsibilities. It has information about the impaired professional program. It has those definitions, like what is the definition of a LPN, LVN, or RN. It has those standards of nursing conduct that's listed there. Those continuing education information, because in order to keep your nursing license, because they do expire, in order to keep them current, you will have to look at your Nurse Practice Act to see what you need to do to renew. And most of the time they have some type of continuing education. Mostly all the states do. And there's a certain amount or certain number of hours that you must actually get within a certain time frame. Okay. So the State Board of Nursing, what does the State Board of Nursing actually do? The licensure and certifies. It has the specialty certifications. It sets the fees, establishes the standards of educational programs. So they actually come to all the different schools of nursing and they look and see, well, hey, are these programs being carried out like we have asked them to? So they're the ones that calculate how much seat time, how long a class is, how many clinicals you need. That's just not stuff that schools and deans come up with. The state boards of nursing come up with all of that information. And then they develop the programs for the impaired nurses as well. And there is help out there. Suspending and revoking license and dealing with the appeal process. So in the event that there's some type of legal action that's taken against that nurse, They're the ones that oversee that suspending, like temporarily halting that nursing from working with their license or actually revoking, taking the license altogether. Okay. If the nurse does something wrong, what's next? A complaint is usually filed to the state board. The complaint is reviewed. An investigation is done. During the investigation, they gather all kinds of evidence, information, looking at identifying to see if there are any gaps, if they need any more information. They may get statements. They may have to look back at camera footage, look at the documentation, policies and procedures, the Nurse Practice Act, the standards, nursing standards. And then the board proceedings is where the nurse has the opportunity to respond during the board proceedings. There's usually a settlement conference, a formal administrative hearing, and then alternative to discipline programs. If it's for an impaired nurse and they have those substance abuse programs, well, they might do that monitoring. The nurse may have to report every so often to do testing. Okay, so the board action, is it immediate? If this is an emergency suspension, do we need to do they take the nursing's license right then? Do they put them on suspension? Do they need more oversight where they're actually working at? And it just depends on what those findings and what that settlement agreement actually is. But there could be financial penalties. It could be jail time. License can be taken. And there can be monitoring, as I mentioned. The monitoring includes the person might have to actually come in and get tested every so often, report to different sites. So we have these two, I like to say, huge file cabinets that keeps information. The nurses is a national database for verifying licensure and any discipline actions for that nurse. So they look up nurse Lucy Liu in this nursing database. Does Lucy Liu have a license? Is it current or has it expired? And also, does Lucy Liu have any disciplinary actions? The nurse practitioner database, before they had this huge file cabinet, if a practitioner, healthcare provider had some type of disciplinary actions, that person could move around from state to state and place to place and no one would know. But now if something happens and it's reported, investigated, and it's, a thing, then they put that information inside this national practitioner database. So in the event that Lucy Liu, I should probably say Daisy Duck, has some type of disciplinary action and she moves from one state to the other. For example, she moves to, I don't know, New York. When she goes to New York and apply for a job, that facility will look inside these two databases to see if Daisy Duck really have a license, if there are any disciplinary actions. And this is another data bank that they actually looking just to verify to make sure that the person, because you can't work without a license. So the nursing license, again, here it is. It has the person's name, their license number, the expiration date of those licenses, because they do expire. And then if yes or no, whether or not they have any disciplinary actions. Okay. Liability is being responsible for something. Liability in nursing is associated with the civil law. It includes contracts, negligence, intentional and unintentional torts. So in the event that something happened to I think we have it. Yes, we have it on another slide. So let me just stay with my slides. I don't want to get ahead of myself. So legal liability, criminal, government versus individual. It can result in felonies or misdemeanor charges. And they're usually where someone has committed homicide, larceny, or embezzlement. And then we have civil. This is an individual against individual. It usually ends up with some type of monetary compensation. But usually someone has done something unintentionally. The patient had a bad outcome and they were not intending to. Here we go over here. So intentional. An intentional tort is intended to cause harm to the client, threat or actual physical harm. They intend to. It's done on purpose. Unintentional tort did not mean to harm the client. I did not mean to hurt the client, but it's still not a defense because, for example, that they give here, the client got the incorrect medication. Well, did the nurse go through the medication rights of administration prior to? If not, or if they did, the client still had some injury, but it was not done intentionally. So negligence. When we ask, student nurses and our healthcare team to assist others without being helped, be that team player, we're not talking about doing anything that's going to allow you to assume the duty of a patient. So once you're assigned to your patients, you have that duty to provide that care based on that individualized care plan, administer those medications, do whatever treatments, check blood pressures, whatever that care plan says to do. In the event that we do not provide those services to our interventions for our clients, and that client has some type of injury, and if that injury is directly related to us not performing that breach of duty, then it equals negligence. So you got 4 elements: duty, breach of duty, damages, and proximate cause. So in the event that your patients are being reassigned, you want to make sure that that's kept up with, because if something happens, well, who was supposed to be taking care of this patient? What they mean is who had the duty, because they want to see who breached the duty. And if they're able to make a connection between the patient's damages or injuries with the nurse not doing what they were supposed to do for that client, then that equals negligence. Okay, here's another slide. Duty refers to the nurse's responsibility to provide that care in an acceptable way. Breach of duty, that nurse did not adhere to that nursing standard of care. What was expected of a nurse? Was it not done, or was it not done correctly? Look at both of those. An expert nurse will come in and look at those standards of care. They'll look at the Nursing Care Act. Damages mean that the client must be able to show that the nurse's negligent act, whether the nurse did not do or what they did, actually injured them. Okay. Proximate cause means that a reasonable cause and effect relationship can be shown between the omission and the commission of the nursing act and the harm of the client. Is there a relation? Did the nurse's negligent act cause the injury in question? Okay. The legal name for professional negligence means negligence by the professional. The most common type of negligence in practical nursing relates to action or lack of action, something that the nurse did not do, or they did something that they were not supposed to do, even if it was not intended. Okay. All right, so battery, that's actual physical. And then assault is an unjustified attempt or threat. They tried to, but battery is an actual physical harm that's being caused to someone. Okay. We have different types of restraints, chemical and physical. Physical, we're used to those. Those are most common. Wrist restraints, leg restraints, a vest. Now, a chemical restraints are medications. If someone's administered a medication outside of its expected use, and it alters that patient in a certain way, it is considered a chemical restraint. An example would be the nurse administered pain medications to all of her patients on the team on her hour sleep round. I didn't say the clients complained of pain or they had signs and symptoms of pain. It just says that the nurse decided to administer those medicines so those clients would go to sleep. So those medicines, in the event their intended use was that the clients were complaining of pain or had signs and symptoms of pain, the nurses decided to administer medication because she wanted the patients to sleep, because usually pain medications alter our clients and it makes them sleepy. So in the event that happens, that medication now is considered a chemical restraint. It was not given for its intended use. Defamation is damages to one's character if it's something is spoken or written. Written is libel. So if we damage someone's character, then through slander, that's spoken, and then libel is written. So we can speak something or write something. We speak it is considered slander, and if we write it, it's considered libel. So be careful when you are actually sharing and reposting stuff. sending an email to the editor of the newspaper, posting on social media, messages or pictures, false accusations on a performance evaluation. We talked about HIPAA, keeping things private. The main focus of HIPAA is protection of that client's privacy. Want to keep things private. If in most facilities, this is an extra task that you can have in addition to your regular task being that privacy officer. All facilities have that privacy officer, and they go in and they provide information to patients about how to contact the facility's privacy officer, and they need assistance with filing the complaint. That privacy officer, most of the time, is a nurse, will be the one that will assist that patient or that client or that resident in finding in actually completing that complaint. So, remember what information you can give out. You got to get permission for certain things. But clients do have a right to have a copy of their medical records. Now, some facilities may ask the patient to pay after a certain page number, especially if they want them printed out. But they do have the right to have a copy of their medical records. So let's look at this one: minimum necessary rule. We want to protect the client's privacy at all times. We have a medical supply company. They're coming into the patient's home to deliver a cane. What information do we need to give out to that medical supply company? They will need the patient's name, their address, because they're actually delivering it, and then how they're going to get paid. They don't need to know what kind of medications the client is on. They don't need to know what kind of diagnosis the client has. We give out the minimum necessary information because we do want to protect that client's privacy. Clients have the right to consent or refuse a treatment. We want to make sure that they have all of the information that they need to make an informed decision. And whatever they decide, they have the right to choose, and we support them in that. So informed consent includes diagnosis and suspected diagnosis, purpose and description of that treatment, expected outcome, expected benefits, possible side effects and complications. If they want to know, some alternative treatments. I know you're saying, I need this surgery, doctor, but what else is out there? What else and what are some possible side effects and complications? Okay, names and qualifications of people who will perform the procedure. What's the prognosis if they know? And then answer any questions the client wants verified. And if the client is headed down to have surgery, they're on the gurney and they're headed down, and the client says, stop, I changed my mind. The client has the right to revoke written permission at any time. They can change their mind, and it's okay. We're not going to continue to roll them on down to surgery. If they're changing their mind, they're changing their mind, and it's okay. So we have these legal documents. We have a legal living will. It does not specify a person to make healthcare decisions. It's a written document that gives detailed information about the person's wishes. Now, a durable medical power of attorney, durable medical power of attorney does name a person. They call them healthcare proxies. This is just saying that someone that's over 18 has permission to make decisions, healthcare decisions for this patient. A living will, that information is in writing and it's not a person that will make the decision. But the durable medical power of attorney, it leaves a person to make those decisions. And these are legal documents. They're valid in all states. So a do not resuscitate order, advance directive based on the Patient Self-Determination Act that gives a physician the legal permission to write such an order. Okay. Okay, I'm going to pause here. Do you have any questions? Oh, make sure you all put your name and your campus and your professor's name in the chat, because these recordings will be shared. Your professors will know whether or not you actually came. So make sure you put your name, your campus, and your professor's name in the chat. Be sure to go back and review your classroom recordings. We have already shared the recordings from Dr. Tenza, Professor Martinez, and then this one will be downloaded and then uploaded and shared as well. So make sure that you commit to reviewing those.
Thank you so much. It was really insightful.
You're welcome. You all take care.
Have a good night.
You too. Thanks. Bye-bye. Mhm.